Thank you. And thanks for having me. And thank you, Rob, for that introduction. As Rob stated, I have been involved in a number of school reopening plans since the summer. And I have reviewed the plan that's been put into place for the upper school by the Health and Safety Task Force for King, looking at everything from masking and the distancing, the hand hygiene, the symptom screening, ventilation. And the plan makes sense. And the plan is very consistent with what most other schools are doing, because these are kind of the standard infection prevention measures that work to help, mitigate the spread of COVID. Um, what we've seen so far with COVID, and I've been taking care of COVID patients since back in March when we first started to see the surge in Stamford. Um, what we're seeing is that while children and adolescents do get infected with COVID-19, the risk of serious disease tends to be low. There are subsets of, there is a serious condition associated with COVID in young children known as MISC, which I'm sure many parents are aware of. That's the multi-system inflammatory syndrome in children, but that's exceedingly rare. And so it's promising, when we're talking about and thinking about having kids in schools and congregate settings for the majority of the day. And I think the fact that children tend not to get as sick with COVID makes us feel a little bit more comfy about making these plans for kids to be in school. And that's coming from, wearing my infectious disease physician hat and also wearing my parent hat, because I send my kids to school every day with those same worries that other parents have. Um, Interestingly, the scope of COVID has really it's changed a bit since what we were seeing in March and April and May, when back then the majority of patients who got admitted to the hospital with COVID, many of them ended up on ventilators in the ICU, and were in the hospital for weeks on end, with lots of complications associated with being hospitalized for a prolonged period of time. We are continue to see some COVID in our hospital, not nearly at the level or the magnitude of what we saw in the spring, but the disease is seemingly a little bit more mild. And I say that cautiously because I don't want to jinx us. And I know it's only mid-October, but this is consistent with what's been seen in other parts of the country that are experiencing second surges, so to speak. That's not where we are now. We are just seeing, a few number of cases here and there. But it's perhaps because there's a few theories. Maybe there's a low level of immunity in the community because this virus has been around for 9 months or so now, or maybe even longer. We're all wearing masks for the most part. And so we're protected from one another when we cannot social distance. And perhaps the level of virus that can infect a person is less because the mask provides that type of physical barrier. And maybe that's why people are getting less sick. We also have gotten a little bit more seasoned at treating COVID. We kind of know what works now and we know what does not work. And we've eliminated those from our treatment protocols. So using things like steroids and remdesivir and, all of those therapies you've heard about on the news, they do work, and plasma therapy. So, it could be a combination of all these things, and maybe that's why we're seeing, patients get admitted with COVID, they're hospitalized maybe for a few days, they go home, they're not ending up in the ICU. It may be too soon to say, but that's definitely what we've been seeing over the past month or two. So, schools have been open for almost 2 months now, since the beginning of September. And um, I think what we're realizing is that COVID is not spreading in schools, at least not yet. We do obviously there have been cases of COVID in the schools in various districts, and that's to be expected because we're in the middle of a pandemic. But there hasn't to date been any clusters associated with uncontrolled transmission within a school building. So there may be students that are affected, but it seems that the majority of that transmission is occurring outside of the school building, whether it be at sports, extracurricular activities, social events, getting infected, from household members, parents, etc. So that is also something that, at least for me personally, makes me feel a little bit better, when I get those emails, as a parent, that there's a case in the district, and, we quarantine this many people, but knowing that, all the proper protocols are followed like they are a king, that, the appropriate people are quarantined, and the risk is really lessened by all of these protocols that have been put into place, and that these health and safety task forces have worked tirelessly to put together. Um, a number of schools in the area, including my own district with where my kids are going, they're using a 3 foot distance between the kids. And I can tell you, back in June, when I started to get involved with my own school district, I was fighting tooth and nail with my elementary students' principal about the 3 feet, because back then that sounded ridiculous. It's like, how can you have the kids be 3 feet from each other? They have to be 6 feet. But then, with realizing kind of more as more data was coming out about children and COVID, and 3 feet is actually pretty good. And the fact that they've been 3 feet apart for almost a month now and doing well and are happy, I'm confident that moving to less than 6 feet, or not being at 6 feet at all times, is actually okay, um, because of all the other things that have been put into place: the masking, the washing the hands, the wiping down the surfaces, the ventilation, etc. So, overall, thinking about COVID and kids and schools, I think that King is making, the right move. And I think this is the right time, knowing the really big upside, and mentally speaking, for children to be in school the majority of the days of the week. I think it's worth, I think that the benefit of that outweighs the potential risks. So in terms of what's going on in Connecticut, I'm sure many of you have seen in the news, the case counts are rising. We are seeing a little bit of a rise. Our numbers have went up in Stamford last week. Our percent positivity went up last week. And our hospitalizations around the state have gone up as well. Again, not nearly to the level we were in the spring. In the spring, the Connecticut hospitalizations peaked at 2,000 patients at once in all of the hospitals in the state. And now the numbers in anywhere between like 150 to 200. So it's definitely not where we were, but it's something we're keeping a close eye on. And a lot of the increase in the state is being driven by an increase in New London County, which is to the eastern part of the state. And there was an outbreak in a nursing home, a couple of nursing homes there, which started to drive that increase in hospitalizations in New London County and Hartford County. And so that's part of the reason why the percent positivity in the state has gone up. So we're keeping a close eye on everything. We're still doing better than 40 other states or 40 other states in the country, which are doing that are red states. So relatively speaking, I think we're doing as expected for mid-October. I think an important thing to know is that those metrics are something that are followed very closely by the governor, by the Department of Health, by school districts, by independent schools like yours and like King. And those are part of the metrics that are going to be used to decide when maybe it's not safe to be in full time, and maybe, we need to pull back and go to hybrid, similar to kind of what other schools are doing, in the state and in Fairfield County. And so I think that, um, because the hybrid model has been used up to this point, and everyone knows how that goes, it's almost like you've gotten good at it. It's something that can be that would be a transition that can happen if it was deemed necessary from a health and safety standpoint for the students and for the staff and for the community. So my biggest piece of advice that I give my friends and my colleagues, and I get this question all the time, is that as parents, it's a matter of being flexible, and knowing that in a given day things can change. But I think that it's time to, it's a good time to take advantage of how things are going so far in the states and in the schools, to get the kids in full time. I guess the question is, should we be testing all the students or the faculty in some regular interval?
Exactly. Yep.
Um, so at this point, regular testing, like that, is really only recommended in congregate settings. And so a congregate setting is where, people are living together. So it's like a nursing home, a group home, prisons, for example. That's where it's been the best studied. When we're talking about schools, K through 12 schools or pre-K through 12 schools, um, everyone's going home at the end of the day, right? So the test result is really only good for that day. The next day that the student comes, or the faculty member comes to work or to school, you have to start all over again. So I think that, I don't think that there's much value added to all of the safety protocols that have already been put into place, like the belts and suspenders. So the masking and the hand hygiene and the screening and the distancing and the ventilation and the wiping of surfaces and all of those, protocols. If you add testing to that, you're not really going to get much bang for your buck, because if a student is sick, they shouldn't be at school, right? And all the kids are wearing masks, and all the people and all the faculty are wearing masks. So, um at this point, I agree that it doesn't really make sense to do the testing, and again, things can change. But at this point, I think that it's just not necessary.
Thank you. Along the lines of testing, do you know, Dr. Shaw, about sort of the COVID testing process at Stamford Hospital? Is that a place that people could use as a resource? That's one of the questions being asked.
Yes, I created the CAT testing
Oh,
center at Stanford Hospital back in March. So we do a tremendous amount of testing at Stanford Health, close to 3,500 tests a week. Testing is available at the main hospital and at the Tully Center, and it's all through a physician order. And so you could have a physician as part of the Stanford Hospital, Stanford Medical Group, or even an independent physician. There are ways, if they're part of our medical staff, to order COVID testing. We're also providing flu testing, strep testing, respiratory virus testing, RSV for kids, and that will be starting, next week. But the COVID testing is up and running. At Tully, it's for ages 8 and above, and at the regular hospital, it's from infant, and above. So yes, lots of testing available. So the state's looking at three main metrics, and these are the instructions that are given to all the school districts, to follow to make these decisions about pivoting, between one learning model and the next. The first is, COVID hospitalizations in the state. That is, so the number of folks that are in the hospital with COVID statewide, and then as well as locally, just kind of helps gauge the severity of disease in the community. And so that's an important metric to follow. The second one is the number of cases per 100,000 population, or you could look at the case positivity rate. And that's just basically telling you, out of a denominator of the total number of tests being done in the state, how many are turning up positive. And so that's the second metric to look at. The third is, An interesting one, which we've started to send data on, is the level or the numbers of influenza-like illness that's present. So influenza or influenza-like illness that's not COVID, that's present in the community, in the hospital. This is data that we send to the state every day now. It started this week. They're looking for the number of people who are hospitalized with the flu, how many cases of the flu are there. I think it's also being used because it kind of tells us what the burden of respiratory disease is in the community and in the state as a whole. And so those are the three main numbers or things that the districts are instructed to look at. Yeah. So what we know about how COVID spreads is that the most common way that it's spread is through droplets. And so droplets are kind of these like big infectious particles that come out when a person sneezes or coughs or sings, and those droplets can travel 6 feet, but then because of their weight, they drop because of gravity. So that's kind of where the 6 feet distance comes from in terms of what social distance means, because we know from infectious disease and epidemiology that viruses and infections that spread by droplet spread, it's really that 6 feet distance where there's that potential. So there's been a lot of work done on this now in the midst of the pandemic. Well, why 6 feet and why not 3 feet and why not 2 feet? Why not 18 feet? There was a big study that came out in the Lancet, which is a big reputable medical journal over the summer, which kind of looked at a whole bunch of studies put together. And what they found was that 1 meter or 3 feet was actually provided protection. And 6 feet provided a bit more protection, but 3 feet was actually okay. And that's where the American Academy of Pediatrics came out, or that's what they used. And part of that research is what they used to make their recommendation over the summer that 3 feet is okay for schools and for kids. Um, we're still learning. And I think while 6 feet is defined as this distance through which a respiratory droplet can spread, I don't know if 4 feet is really less good, right? I think in the setting of using masks and doing all these other things and these safety protocols that have been put into place, 4 feet I think is okay. Um, so that's kind of what I would say about that. So, I'm familiar with the CDC guidelines about airborne transition and aerosol transmission of COVID. So what that means is, so we just talked about droplet spread, right? So that it refers to the size of the infectious particle. So infections that are spread by aerosol or airborne are smaller and they can travel further distances, so further than 6 feet. And so there have been some isolated incidents described in the medical literature of spread of COVID in these types of situations where it's potentially further than 6 feet. Most notably, it's choirs singing in poorly ventilated, closed spaces without masks on, doing, and then any type of activity that requires heavy breathing. So for exercising, for example, again, but in poorly ventilated rooms without masks. So this type of spread of COVID is exceedingly rare. I actually am in the middle of attending the biggest infectious disease conference virtually. It started today, and there's a bunch of work that was presented in a lecture this morning about the difference between aerosol and airborne. So a lot of these studies show that these virus particles can be tested in the air. They sit in the air for 30 minutes, but if you actually try to put culture that virus in the lab, you can't culture it. So for simplicity's sake, just because you can detect COVID in an air sample, it doesn't mean that it can make someone sick. So that's kind of the difference between aerosol, where something can be present in the air, but if it's airborne, that means you can actually get sick from it. If COVID was truly an airborne disease, we would have had all be wearing N95s in the community since spring. And that's just not the case because string masks don't protect against infections that are spread by an airborne route. So we feel very comfortable and saying that this is primarily an infection that's spread by droplets, which is why the string masks and the cloth masks work. So the gold standard and the preferred test for COVID is the PCR test. That's the test that tests the actual genetic material of the virus, and the most common and accurate way to collect that specimen is through the nose. It's a nasopharyngeal swab, so it goes back all the way back into the back of your nose, and it's not comfortable. So that is the best test for COVID. It also can be done by an oral swab, and that's the only testing that we are doing through Stamford Hospital. The turnaround times on the PCR tests can be anywhere from, you know, 20 to 30 minutes if it's done on the rapid Abbott machine. So, if you're in an emergency room or in the intermediate care center over at Tully, it's very quick. If we send it out to a commercial lab, the turnaround time is usually 24 to 48 hours, so not too bad. Um, and then the other test is the antigen test, which is the quick test, which is a nasal swab, so the front of the nose, and then sometimes they do the deep nose swab as well. That detects the proteins on the surface of the virus, so not the genetic material. The antigen test is quick. The turnaround time is like 15 to 30 minutes. Easy to do and cheap, but we're really concerned about its accuracy and its sensitivity. Um, We've seen studies that report a 60% of false positivity rate with antigen testing when used in congregate settings. So, like a nursing home in Nevada, they studied this against a PCR test, and they found 60% of those individuals actually did not have COVID, but the antigen test said that they did. So, the antigen test is really useful in very certain scenarios. And so we do not recommend it to be used widely. So if you need a test, if you're sick or your child is sick, the recommended way to go is to get a PCR test. Other things out there are the saliva test, which many people have read about. That's what the NBA was using in the bubble. It was created by Yale. It's called Saliva Direct, and it is not ready for prime time. It's not commercially available yet, but I do think it's a promising method. It also is a PCR technology, but probably won't be widespread available until next year. I think the main thing about the winter is that we get concerned about respiratory viruses that are seasonal,
Mhm,
that we see more in the winter, the main one being influenza. Um,
mhm.
but we do see more respiratory viruses in the winter, but I think that's largely driven by the seasonality of the viruses themselves.
Mhm.
Um, I'm not familiar with it being related to the air quality or the air being drier.
Thank you.